next exciting speaker is Dr. Lou Atkins, who I had the privilege first to meet at the University College London Behaviour Change course only in August, and it was fantastic. Lou Atkins is a researcher, trainer and consultant in behaviour change, intervention, design and evaluation, something that's probably sadly missing at times in our health system. As a senior teaching fellow of the University College of London Centre for Behaviour Change, she leads actually the Australasian Hub. So we're very privileged that she's decided to at least give this hemisphere a bit of a go, and she's based herself in New Zealand with the family. Lou is involved in a number of projects to improve health and well-being through the application of behaviour change theory to intervention design to change health, professional behaviour, prevent and manage illness and promote environmental sustainability, everything that we should be focused on. Together with Professors Susie Michie and Robert West, Lou co-authored the book The Behaviour Change Wheel, A Guide to Designing Interventions, which I've got, which I would thoroughly recommend. She's a registered chartered psychologist and associate fellow of the British Psychology Society. Lou is a regular speaker actually at the national and international scientific meetings and in the UK government departments, including Department of Work, Pensions and Treasury. So if we could warmly welcome Dr. Lou Atkins. Thanks.
Thank you for that introduction. Morning, everyone. Thank you so much to the conference organisers and particularly Kate for inviting me here today. You guys have been a great champion of our work. So, Centre for Behaviour Change, where I'm sort of remotely based to the tune of about 13,000 miles away in Auckland. Now, we set up the centre in 2014, and it grew out of the work that we were doing in the health psychology research group, which was looking largely at how do we improve delivery of healthcare services, which of course requires supporting healthcare professionals to change in some way. And the centre is very much about it's a pan-discipline centre because it recognises that when it comes to changing behaviour, it's not the preserve of just psychologists, it's everybody. It's everybody's interest to do that. And people bring different perspectives together, different tools, models together to view behaviour. So we function as a hub to increase the quality and quantity of research and then translate that through summer schools, as Marg mentioned, training and talks such as this. So just to acknowledge Susan Michie and Robert West, co-authors on the book that Marg mentioned, and also my lovely chums in the health psychology research group at UCL. So, let us start with the humble pill. We use it. Well, I don't prescribe it. You guys prescribe it. You use it. What assumptions do we make about it? Well, we assume, for the most part, that we know what's in it, we know how it works, and the context in which we use it is after examining a patient and arriving at a diagnosis, deciding when to use that pill. Do we broadly agree with that? Cool. So, we know that that can change health. We also know that health professional behaviours affect health. We know that there's a gap between what's in evidence-based guidelines and what happens at the coalface. Research coming out of the Netherlands and the US showing patients not receiving evidence-based care, care that was unnecessary or harmful. And each one of these requires behaviours to change at various different levels. And of course, they're going to differ across contexts with different barriers and facilitators to change. Now, we've got an emerging picture of some stuff that works. What works to change health professional behaviour? There's evidence from Cochrane reviews, audit and feedback, tailoring interventions, setting goals and action planning, CME programmes, So we've got bits of stuff of an emerging picture. But do we know when to use these strategies? Are there other things out there that might be effective? And of course, we need the right fit between problem and solution. And I would put it to you that compared with the humble pill and its rigorous scientific development and evaluation, when it comes to behaviour change, which also impacts on patients' health, there's room for improvement in terms of how rigorous and scientific we can be. And I'm sure you can think of examples, I can certainly think of examples of interventions that have been designed using the Islagiate principle of intervention design. Very important principle in behaviour change, stands for... So a bit of levity, but essentially to encapsulate the fact that we start with a problem, we want people to change, and we jump straight to intervention. And what we miss out is actually understanding the behaviours that we're trying to change. So in this talk, I'm just going to be opening the door on some of the tools that are out there that may be helpful, either in a research or in a clinical context. And also some guiding principles. So, principle number 1. Thinking in systems. Behaviours don't occur in isolation. If we are seeking to change a particular behaviour, it is part of a system that exists in context, that constantly evolve. It is influenced by and influences other behaviours. And it might be that a particular behaviour that we want to change, there is a more optimal entry point somewhere else in that system. The example I gave yesterday in the workshop, we might want somebody to go to the gym. That's the target behaviour. But there are other behaviours that it might be easier to target that might increase that probability, such as if you target getting that person to put their gym kit by the door, it might increase the probability and you might have greater chance of changing that behaviour than focusing your attentions on going to the gym. Second one, less is more. We're tasked with limited, under the context of limited resources, limited time, funds, of getting the biggest bang for our buck. And the tendency is to go in and try and effect as much change as quickly as possible. But unless we have the resources to understand the behaviours that we're trying to change, we're most likely going to miss the targets. So the kind of principle that we work to is just start with 1 or 2 behaviours, start building on small successes, because also if you have a more targeted approach, small successes, you are going to bring people in rather than doing the kind of one-hit wonder. It doesn't really change, and the next time you try and effect change, people are kind of disengaged. But if you can actually demonstrate success and then build on that iteratively. Third is to be systematic, comprehensive, and account for context. And I will just give examples of that through the tools that we'll see shortly. And finally, that behaviour change is iterative. When we're trying to design interventions to change behaviour, we are not following a linear path. We are going to be cycling back and forth, and certainly in the task we were doing yesterday, you can select a behaviour to change. You can go down the route of trying to understand what the influence is on that. And in doing that, you realise, actually, we're targeting completely the wrong behaviour. We need to go back a step. That's the nature of the beast. So, to understand behaviour, to change behaviour, we need to understand it, why behaviours are as they are, and what needs to change for the desired behaviour to occur. And of course, we say here, crucially, in context. This is going to differ. The same behaviour will differ according to who's performing it, what setting it's in, region, country. So here is the most simple model to start thinking about organising what influences behaviour, called the combi model. For any behaviour to occur, 3 things need to be in place. So in that sense, behaviour change is really, really easy. All you need to do is ensure that people have the capability, the opportunity, and the motivation to act. I say really, really easy. Changing behaviour technically is easy. changing behaviour ethically and within a budget, that's where it gets messy. So, capability. We need the knowledge, we need the skills, we need the physical strength and stamina. But also, we need to be motivated. And we divide this into reflective motivation, so that's our intentions, our cost-benefit analysis, things where our deliberative processes. But also automatic motivation, our habits, our desires, our routines. So we can know what to do, have the motivation, the desire, think something's a good idea to do, but we also crucially need the opportunity to act. So we need the physical opportunity, we need the time, the money, the resources, the right equipment, but also the social opportunity. Coming back to Ian's talk, the sense of connectedness, the influence of others. Is the behaviour that you're tasked to do something that others want you to do, that you see other people doing? And it's very often these things that get missed when we're trying to change behaviour. We're great at furnishing people with all the information they need without necessarily thinking about the social context within which they need to employ it. So we've got a tool for thinking broadly about, for behaviour to change, what needs to change in terms of capability, opportunity and motivation. And this is not new science. This is centuries old. This is enshrined in US jurisprudence. For anyone to be found to be proven guilty of performing a criminal behaviour, you need to prove what? They have the motivation, opportunity, and the means. Means, motive, and opportunity. So we've changed that slightly differently here to capability, opportunity, motivation. And there's a reason why that's enshrined in US martial law, is because it's a comprehensive summary of all of the things that might influence behaviour. So when you're thinking about, right, we want people to do X, thinking through the lens of COMBI, thinking, do they know what to do? Do they value it? Is there anything in the physical or social environment that might prevent them from doing it? Is a helpful way of kind of being comprehensive when thinking about changing behaviour and trying to understand what needs to shift. And yes, this is used often in the research literature. It's used in kind of questionnaires, interviews and focus groups, also to code documents, and has been used in observation as well. And that's great. But if you're time and resource poor, literally sitting down and having a structured discussion that's structured around those pillars can be as helpful. The point is, use what you can in the time that you have to get the greatest understanding of the behaviours you're trying to change. So we've got a tool to understand behaviour, but what do we do with that understanding when we've worked out what needs to change in terms of people's motivations or their capabilities? Where do we go next? And that's often where a lot of theories kind of fall down, is because you can get an understanding of something by using a theory. And as I was saying yesterday, nothing gets practitioners running for the hills quicker than when psychologists start talking about theory, and you just like, Christ, how am I going to implement this? So we've got to make it useful and usable and signpost to, okay, if that's the state of play, here's what you might consider going in your intervention. So there's tons of frameworks out there that are to guide the design of interventions. And about 6-7 years ago, Susan Mickey, who directs the Centre for Behaviour Change, did a review of all of these. And a lot of them came out of health. Some of them were social marketing. Some of them were public health, environment. And they rated them according to 3 criteria. So were they comprehensive? Did they consider all of the menu of ways in which one might intervene? was it coherently structured? So you had a systematic method for selecting them, and were they linked to a model of behaviour? So you could draw on your understanding of the behaviour and link that in. Now, none of them met all three of those criteria. So they did the next best thing and just synthesised them and optimised the learning. And the result of that was what they called the behaviour change wheel. So what this is an overarching framework. You can see the combi model laid out at the centre. So it starts with understanding the behaviour, and then around that you have 9 what we term intervention functions. And essentially it's what you want what function you want an intervention to serve. So you might want, and interventions serve numerous functions. You might want it to educate people. You might want it to persuade people, sort of change their feelings about performing a behaviour. You might want it to incentivise folks and promise rewards, or on the flip side, create the expectation of a punishment through coercion. You might want it to serve the function of training, imparting skills, or enablement. We'll come back to that one. It might serve the function of modelling. So demonstrating the behaviour in a way that one can that is an example for people to imitate or aspire to. You might want it to restructure the physical or social environment, or restriction, so using rules to reduce opportunity to engage in the behaviour. Now, being transparent about the limitations of any framework, when they were synthesising them, all of these different ways of intervening, they kind of fell neatly into 8 of those categories, and then they were left with kind of like surgery and social support and counselling and pharmacological interventions. And they kind of put them into a bit of it's like the kind of spare room of interventions where they threw all of this stuff. And they defined it as anything that increases means or reducing barriers to increase capability that isn't technically education or training, or opportunity that it goes beyond environmental restructuring. And that's the kind of downside, as Robert West, who's one of the architects of the wheel, said. Basically, the broad definition of enablement is, if it's not anything else, it's enablement. But the limitation. And so it allowed us to be as comprehensive as the literature at the time allowed, but we also need to be systematic. And this matrix, the shaded areas, suggest, depending on what you want to change in terms of capability, opportunity, or motivation, you might consider the shaded areas in terms of intervention functions. So I'll lay that out just a little bit easier. So if we know that some aspect of people's capability needs to change, we might look at kind of education, training, enablement. Motivation also includes, as well as those education and enablement, sort of persuasion, incentivization, so on, an opportunity. And what this is trying to do, just as a link up, is to make sure that we get that right fit of the solution to the problem. And it sounds really simple, but certainly in the UK, and one of the examples we talk about in the book is that, millions and millions of pounds were spent incentivising GPs to provide smoking cessation advice. So they got in what was the quality outcomes framework. If they said they were providing smoking cessation advice, they got paid for it. Now, if we're talking about incentives, we're assuming, motivation's the issue. Wasn't the issue. Millions of pounds were spent, no demonstrable change in quit attempts, quit rates, NRT prescriptions, and a simple kind of combi analysis, as they did, kind of post hoc, was they're really motivated to do it. They have a tiny amount of time, and you're opening a whole can of worms when you start with the smoking, because you allow people to rehearse all of the reasons why it's not a good time for them to give up smoking. So, and also the capability to, in terms of the communication skills, to marshal that discussion. And so as a result of it, they developed a 30-second, very brief advice, and I know you have the 5 A's here, just to be able to deliver that smoking cessation advice that targeted the opportunity and capability issues. So we've got suggestions of different functions our intervention might serve, depending on which aspects of capability, opportunity, or motivation need to change. But how do we zero in on those? And so again, to allow us to be systematic in our approach and account for context, we've developed what we call the appease criteria, and it's just a list that goes, okay, so we've got a choice between incentivizing or persuading or coercing or educating. If we want to change people's reflective motivations, which one of those is appropriate for our case, for our situation? So which one is most affordable? Which one is practicable to deliver in terms of being able to scale up? Which is likely to be effective or cost effective? Which is acceptable to those delivering, receiving, commissioning it? Are there any side effects, unintended consequences if we choose a particular route? Or equity? Does it disadvantage one group or another? And that's just, again, a simple checklist to run through, and again, marshal discussions, so you can be kind of efficient in terms of your design process, and knowing that you have taken account of context and been systematic in moving through that intervention design process. So we've got a way of tools to understand behaviour, signposts to broadly functions our intervention might serve, but there's a ton of different ways you can educate or persuade or incentivise. So how do you go into more detail? And it was only in 2008 that there was the first attempt at a standard language to describe techniques to change behaviour, or behaviour change techniques, or BCTs. 2008. So is there any wonder why we kind of lag behind in terms of behaviour change research when there was nowhere, I mean, imagine that with, drugs. There's standard names, and for good reasons, a standard language. But we needed that with behaviour change techniques as well. So we're talking about essentially the active ingredients, the smallest component that are observable, measurable and replicable, and a common language. So things like goal setting or self-monitoring or practical social support. These are sort of ways that they can be delivered in various ways, but are a standard way of describing how we are seeking change. And so this is the most recent version is 93 techniques, which there is an app, so you can carry 93 different ways to influence your fellow colleagues over the next couple of days. And of course, this was developed at a different time to the behaviour change world, but there's obvious synergies between them. So what we did in the book was link all of the techniques to the functions. So when you alight on, right, we know following this process, we know that persuasion is something that we need to have. How are we going to persuade? Then there's techniques suggested there, and again, the appease criteria to start to zero in. So let me give you just a quick example of applying these tools in practice. So you guys don't need me to explain this slide to you at all. So I'll let it speak for itself. So implementation of sepsis guidelines in the UK. So the Sepsis 6 clinical care bundle, fluids, antibiotics, oxygen, urine output, blood cultures and lactate. Picture the scene, a not so sleepy North London hospital. They had implemented Sepsis 6 and they had this kind of implementation package. So there was a bit of training and education, a bit of audit and feedback, some ward changes and some staff support. And their target was 95% compliance. And they tried for 3.5 years, and they tried tweaking their implementation package. And when I say tweaking, in the A&E department, they tried 45 iterations of the protocol and still were not achieving target. So they brought Centre for Behaviour Change in and to help them achieve the target of 95%. And we're still on that process, but to clue you into the first part. So our first part was, well, what's in? What exactly are you delivering? What techniques are you using? And they said, well, we don't really know. So, okay, so step one, find out how they're trying to implement it. So we used that behaviour change techniques taxonomy and we observed what they did. We looked at the protocols and any other relevant documents, and we interviewed staff, and we identified there were 19 techniques that they were using. Okay, so you've got these 19, but that's still not getting you to where you want to be. We also retrofitted it onto, you've got these 19 techniques, how are they trying to achieve change? Well, they were trying to achieve change largely by changing capability, some aspects of knowledge, and also changing motivation, the beliefs about the consequences of implementing it and specific aspects of beliefs about their capabilities. So, okay, so we know what you're delivering and we know how that's intended to change. Step two, find out where the gap is, because obviously that package in and of itself isn't getting people to where they want to be. So what are the barriers and facilitators to implementing it? 41 staff interviewed, and again using the combi model as a basis for the interview guide. So capability barriers. Not sure what to do when there isn't a definitive diagnosis. Not sure if the patient's been in hospital a while. Not sure when oxygen's been started. Not sure when fluids have been started. Motivational barriers, fear of harming the patients, concerns about giving patients antibiotics in the absence of a definition or large volumes of fluid. Confidence in the evidence base, and related to that, kind of needing to believe that this is actually worthwhile doing, that there is an evidence base behind it. And finally, opportunity, lack of communication between clinical care teams, and a conflict between doctors and the nursing staff. Because this care bundle, the perception of some physicians, was taking power out of the hands of doctors. So there was a conflict there, and also in the a separate opportunity issue was that doctors wouldn't get there in time at night. At the hospital night coordinator was to be a junior doctor that wasn't trained to implement Sepsis 6. So what was going to make it fly? Well, they certainly remembered, it was certainly on their radar because there was good kind of branding and marketing. Beliefs about consequences. They saw that when they implemented this, patients improved immediately and they were to follow up specific patients. In terms of environment, having the materials and resources there, seeing superiors' commitment to this care bundle, and also empowerment that it's their care pathway that they were able to implement. So, what we were able to do, based on that, is to make modifications to the existing care package. So there was we made modifications to some of the existing, such as the education, the training sections, and some of their written materials, but also added in 2 new components. And crucially, one to address this disconnect or this sort of conflict between the doctors and the nursing staff, which was a partnership agreement where all clinical teams signed up to delivering this as equal partners in delivering this clinical care bundle. And second was education for the night coordinator. So we were able to be much more specific about what was being delivered, what needed to change, and articulate in particular what those particular behaviour change technique changes were using those tools. Coming to an ICN near you, Belinda Monroe and Kate Curtis, who will be presenting, I believe, on Friday, will also show other examples of how these tools are applied in the clinical setting. And so to wrap up, if we understand the behaviours that we're trying to change, if we're systematic about how we select from a comprehensive list of behaviour change strategies, and we articulate what it is that we're actually delivering, and also have a way of systematically accounting for context, We can be completely transparent about what we've done and therefore increase the learning and contribution to the literature. We can be accountable when we're asking for more funds or more time to do something. There's a rationale for why we're asking for that. And ultimately, that best serves those that we're supporting to change and those who benefit from that change. So that's primarily you guys, work colleagues, patients, family, friends, so on and so forth. So with that, thank you very much for your time.